A 34-year-old man presents with chest pain for 4 hours, resolved at presentation. He has been smoking marijuana, which he obtained from an unknown source. His vital signs are 98.6 degrees Fahrenheit, 115/20, 167/95, 98% Ra. His physical examination reveals pupillary dilation, tachycardia, and diaphoresis. His electrocardiogram, EKG, demonstrates ST depressions in V3, V5. Initial troponin level is 0.20 ng per ml. Which of the following is the most appropriate therapy at this time? Percutaneous transluminal coronary angioplasty, PTCA. B. Tissue plasminogen activator, TPA. C. Abciximab. D. Metoprolol. E. Aspirin. Pause the video for a moment. Answer is E. Aspirin. The patient is exhibiting a sympathomimetic picture after smoking marijuana, which commonly occurs because of crack cocaine additives. His myocardial ischemia is likely because of a combination of vasospasm and hyperaggregatory platelets. Aspirin is indicated for treatment. His chest pain is resolved, and he is not having a cent segment elevation myocardial infarction, so PTCA, TPA, and GPBA inhibitors are not warranted. Metoprolol is relatively contraindicated in cocaine-induced chest pain as there is a theoretical risk of reducing cardiac output by inhibiting beta receptors in the setting of increased peripheral vascular resistance due to alpha receptor stimulation. Which of the following EKG changes may be seen in the setting of hypercalcemia? A. ST segment depression. B. QTC segment shortening. C. Widened T wave. D. Bradycardia. E. All of the above. B. QTC segment shortening. Answer E. The most commonly cited abnormality is QTC shortening, but any of the listed changes may occur. An 82-year-old female taking digoxin for congestive heart failure, CHF, is brought to the ED with confusion and an arrhythmia. Her blood tests subsequently reveal a supratherapeutic digoxin level. At baseline, the patient is not known to have any rhythm disturbance or block. Which of the following rhythm disturbances is most likely present? Sinus bradycardia with multiple premature ventricular contractions, PVCs. B. Atrial fibrillation with rapid ventricular response. C. AV nodal reentrant tachycardia. D. Sinus tachycardia. E. Morbid's type 2 second-degree heart block. A. Sinus bradycardia with multiple premature ventricular contractions, PVCs. Digoxin toxicity may result in nearly any rhythm disturbance. However, PVCs are the most common and typically represent the earliest rhythm disturbance. The key point is to recall that digoxin toxicity exerts its effects in two ways. Increased vagal tone leads to bradyarrhythmias and AV block, while increased automaticity leads to frequent ectopic rhythms. The hallmark of digoxin toxicity is when these two conditions are combined, as in the often cited paroxysmal atrial tachycardia, PAT, increased automaticity, with AV block, increased vagal tone. However, sinus bradycardia, increased vagal tone, combined with PVCs, increased automaticity, is much more common. Rapidly conducted atrial dysrhythmias, e.g. atrial fibrillation with rapid ventricular response, or SVT, are not observed because of the high degree of AV block associated with digoxin toxicity. However, since digoxin continues to be used as a second-line agent in patients with atrial fibrillation, many patients with digoxin toxicity present with atrial fibrillation, which is their baseline rhythm, as opposed to a result of drug toxicity. Other common findings include bradydysrhythmias, junctional tachycardia, and bidirectional ventricular tachycardia, which, along with PAT with block, are frequently considered pathognomonic. While digoxin toxicity results in AV block, Mobitz type 2 second-degree AV block is among the least common rhythm disturbances caused by digoxin toxicity.